The assigned topic that we will be covering for the 2514 final project is ulcerative colitis. We will be discussing the pathophysiology, pharmacology, and assessment of ulcerative colitis. This presentation was created by myself, Tehgan Martin, Jenna Kowerko, and Guri Marahar. First off, what is ulcerative colitis? Ulcerative colitis is one of the two types of chronic inflammatory bowel diseases. Ulcerative colitis is characterized by inflammation and ulcerations in the inner lining of the large intestine. Ulcerative colitis only affects the mucosa and submucosa layers of the intestinal wall of the rectum and the colon. Crohn's disease is the other type of inflammatory bowel disease that differs from ulcerative colitis because it can affect any part throughout the GI tract and is characterized by skip lesions that involve the entire thickness of the intestinal wall. To better understand the pathophysiology of ulcerative colitis, it is important to understand the functions of the colon. The colon and rectum are part of the large intestine. It is the final part of the digestive system. Its primary role is to reabsorb fluids such as water and electrolytes and process waste products from the body to prepare for its elimination. The exact cause of ulcerative colitis remains unknown. Diet and stress were previously suspected, but now it is known that these factors only contribute and trigger ulcerative colitis but are not the direct cause. Ulcerative colitis is suspected to be an autoimmune disease. Although the precipitating factors involved in ulcerative colitis are poorly understood, the onset of the disease includes an inflammatory response. Specific pro-inflammatory cytokines, such as the tumor necrosis factor alpha, contribute to promoting this inflammation process. Inflammation in ulcerative colitis begins in the rectum and extends proximally along the colon in a continuous manner. The inflammation caused by ulcerative colitis involves the mucosa and submucosa layers of the gastrointestinal wall, with an alternate period of recurrent flare-ups followed by symptom-free periods of remission. The affected area of the mucosa of the rectum and the colon presents with an increased amount of blood and appears abnormally swollen with fluid. Multiple abscesses develop in the intestinal glands, which are referred to as the crypts of Lubricon. The abscesses break through the crypts into the submucosa, which results in ulcerations. These ulcerations destroy the mucosa epithelium, which leads to bleeding and diarrhea. In addition, a loss of fluid and electrolytes occur because of the decreased mucosal surface area for absorption. The breakdown of cells results in protein loss through the stool. Areas of inflamed mucosa can also form pseudopolyps, which are tongue-like protrusions into the lumen of the colon, which further decrease the surface area for absorption. The colon becomes shortened from the mucosa musculature thickening as granulation tissue develops.
Okay, let's talk about how our patient might represent with ulcerative colitis. So the first most common thing that you might see in your patient is fatigue. The patient might appear tired. This is because of the massive dehydration, the loss of electrolytes due to the diarrhea, and also because of the frequent bowel movements they're having because of inflammation in the colon. Another thing that you might see is fever. Well, fever is happening because of the inflammation that's going on. And with inflammation, we have an immune response. And part of that immune response is fever. Some other things that you might see is diarrhea, weight loss, and dietary intolerance. Diarrhea is happening because of the inflammation that's causing frequent bowel movements and also causes our colon to contract and empty frequently. Along with that, we also lose the function of our large intestine, which is to absorb water from the contents coming from the small intestine. Further, we might have weight loss, while this is due to, the frequent bowel movements and the loss of appetite, as the patients don't feel like eating because of having to go to the bathroom so often, and also because of the fatigue they're experiencing. With that being said, diarrhea may appear bloody and may contain mucus and pus. Well, this is because with inflammation, this kills our cells of the colon, and when the cells die, they form ulcers. These ulcers start producing mucus, pus, and blood. So when the contents from the small intestine enter into the colon, they go over these ulcers, collecting the blood, mucus, and pus, which appears in our stool. And this is what it causes our stool to appear bloody, mucus containing, and pus. With this, we can also experience anemia, which is a loss of blood due to that bloody diarrhea. So another symptom that our patient might represent with is lower abdominal pain and tenesmus. Again, the abdominal pain might depend on the severity of the damage occurring from the inflammation, and tenesmus is basically because of the inflammation that's encouraging our colon to contract and empty frequently. Okay, now that we have discussed some of the basic clinical manifestations, let's also take some time to look at the severe symptoms that might appear if this disease becomes severe. So one thing that can happen is rupturing of the colon. Well, this can happen because of the flare-up period and the remission period, which is basically the healing accompanied with inflammation again. Once this happens, we have that repeated inflammation, there's repeated production of ulcers, and the lining of the colon isn't able to handle that. And with these repeated ulcerations, there is formation of holes within the bowel, which causes the intestinal fluid to leak into the abdominal cavity, leading to peritonitis. This is severe, as this might cause sepsis and shock. So we can have toxic megacolon, which is again repeated inflammation can cause the colon to distend, and with distension, the colon can become paralyzed, it can become toxic, and can rupture again, exposing to peritonitis. Some typical signs and symptoms of peritonitis can include abdominal distension, fever, diarrhea, abdominal pain, dehydration, and tachycardia. So if you see your patient experiencing any of these, this could be an alarm for peritonitis. And to wrap everything up, please remember the word ulcers, as this will help you remember what the signs and symptoms a patient might represent with ulcerative colitis. Okay, now let's move on to the nursing assessment that we'll perform on our patients. So within the subjective data, we want to know about their past medical history. Ulcerative colitis is highly associated with family history, so it's good to know if the patient has any family history of inflammatory bowel disease. It's also good to know if they had any infection or any autoimmune disorders, as this might cause harm to the colon. You want to know about their appetite, their weight, if they had any weight loss, pain scale, OPQRST, onset, quality, radiation timing, etc. You want to ask them about their bowel movements, how often are they going to the bathroom, how does their stool look like, and at last, you also want to know about their medication, what kind of medications they're taking, antidiarrheals, etc. Okay. Within the objective data, I would start off by observing my patient. So observe for any signs of fatigue, monitor their vital signs. Is there a high temperature, which may indicate fever, high heart rate, high respiratory rate, which may indicate peritonitis, and also is there a decline in blood pressure. I would check their skin for any signs of dehydration, dry mucous membranes, pale skin, or any poor skin trigger. And then I would do a focused GI assessment, which may involve starting with inspection, look for any signs of distension, auscultate for bowel signs. Are they hyperactive, hypoactive, or is there absence of bowel sounds? Check for rebound tenderness, do light palpation for pain. To wrap everything up, I would try to make connections with toxic megacolon and peritonitis, and if the patient is experiencing any signs and symptoms related to those diseases, as these may involve immediate action. As of diagnostics and labs, I can expect the physician to order the following lab tests. This could include complete blood counts, CBC for anemia or elevated white blood cells. There could also be tests for inflammation, such as CRP, so C-reactive protein, and tests like ESR, electrocyte segmentation rate. We could also look at the electrolyte panel to measure for any loss of potassium. There could be tests such as stool tests, culture and sensitivity, and inoculant to rule out any infection. With ulcerative colitis, patients are at risk for colorectal cancer, so it's also important to screen for that. Sigmoidoscopy could also be ordered. This will help look at the lining of the rectum and segment colon to actually take a picture and see what is happening in those areas. Colonoscopy could also be performed, which looks at the lining of the entire large intestine. And along with that, biopsy could also be performed. This will help detect any precancerous changes or any colon cancer. So barium enema could also be performed. This is an X-ray used to assess the colon. Enema is given through the rectum, which will help light up the rectum and help take those X-ray pictures. And it will actually help with the anatomy of the colon and will help the physician look at where the ulcerative colitis is happening.
The medication we have been assigned is sulfasalazine, which is one of the 5 aminosalicylates. Sulfasalazine is a prescription drug that is an oral tablet. It is available both as generic drugs and as brand name drugs, known as Alzalfadine. Sulfasalazine relates to the inflammatory bowel disease, ulcerative colitis, as it is a gastrointestinal anti-inflammatory medication. Sulfasalazine is used for the treatment of ulcerative colitis. It reduces the inflammation in the colon as well as increases the duration time between the ulcerative colitis flare-ups. It is indicated alone for patients experiencing mild to moderate pain, but may be used in combination with other drugs for more severe cases. Sulfasalazine is expected to affect the immune system and decrease inflammation. It is metabolized by intestinal bacteria into 2 compounds. The first compound is 5-aminosalicylic acid, which is responsible for reducing the inflammation in the colon. It is likely to reduce inflammation by suppressing prostaglandin synthesis as well as the motility of inflammatory cells into the affected region of the colon. The second compound is sulfapyridine, which is responsible for the side effects. These 2 compounds are delivered to the colon to decrease inflammation in the lining's connective tissue. This drug is partially absorbed, and its peak is 1.5 hours to 6 hours. The duration is 6 to 12 hours, and the half-life is 6 hours. The drug is excreted in the urine as sulfasalazine, sulfapyridine, and 5-aminosalicylic acid and metabolites. The therapeutic effects that can be evaluated by the nurse include frequent vital signs, specifically watching the patient's temperature return to a non-febrile degree. The absence of mucus in the patient's stool is also a therapeutic response and can be monitored by obtaining a stool sample. A patient will experience most effective treatment of sulfasalazine while experiencing mild to moderate ulcerative colitis, whereas someone with severe ulcerative colitis will likely need other drugs in combination. Now we're going to take a look at the side effects. Some important common side effects to monitor for with sulfasalazine include nausea, vomiting, and abdominal pain. These can be monitored by doing gastrointestinal focused assessments as well as obtaining subjective data via gastrointestinal pain related questions. Patients may also experience elevated temperature, therefore frequent vital signs focusing on the temperature will be critical for monitoring. Another common side effect is a rash. This can be monitored by performing integumentary focused assessments. Lastly, some common hematological related disorders include agranulocytosis, hemolytic anemia, and macrocytic anemia. That being said, frequent complete blood counts should be obtained periodically. While a patient is receiving sulfasalazine for ulcerative colitis, it is important for the nurse to consider certain implications, such as observing the patient's stool's consistency, amount, characteristics, and frequency. It is also significant to monitor for abdominal pain, cramping, or any visible blood or mucus. For a patient receiving long-term treatment of sulfasalazine, the nurse should assess the patient's renal studies, such as blood urea nitrogen levels, creatinine levels, and a urinalysis. It is also very important to monitor for any allergic reactions where the patient would show signs of rash, dermatitis, urticaria, pruritus, dyspnea, and bronchospasms. Lastly, it is crucial to monitor for blood dyscrasias by monitoring for skin rash, fever, sore throat, bruising, bleeding, and fatigue. It's also important to assess their complete blood count before therapy and every 3 months. Lastly, some patient education may be required in order for the patient to receive optimal effects. To prevent crystals in the urine, the patient is advised to take the tablet with a full glass of water. It is possible the patient will develop burns while exposed to sunlight. That being said, they should be informed to avoid sunlight or wear sunscreen. It is also important to let the patient know that they may develop a yellow-orange color in their urine, contact lenses, or skin. But this is nothing to be worried for. Most importantly, the patient must be educated to notify a healthcare professional immediately if they develop any life-threatening symptoms such as skin rash, a sore throat, fever, mouth sores, or any unusual bleeding or bruising. In summary, we discussed the pathophysiology, assessment, and pharmacology of ulcerative colitis. Ulcerative colitis is a chronic inflammatory bowel disease that causes inflammation and ulcers in the lining of the rectum and colon. Clinical manifestations can include fatigue, fever, diarrhea, weight loss, and lower abdominal pain. An example of treatment can include an anti-inflammatory medication known as sulfasalazine. Thank you!